Hello, welcome to this presentation titled Implementation and Clinical Utility of a Computer-Aided Risk Score for Mortality, CARM, a qualitative study. My name is Carolyn McCrorie. I'm a Research Fellow in Patient Safety in the Digital Innovations theme at the Yorkshire and Humber Patient Safety Translational Research Centre. My co-authors listed here include academic, clinical and patient and public involvement and engagement colleagues. The background to this evaluation is that early assessment and management of medical patients admitted to hospital in an emergency is a critical factor in ensuring safe quality care. Changes in physiological measures such as respiratory rate, blood pressure and heart rate are known to predict deterioration, and rapid response systems such as the National Early Warning Score or NEWS supports detection and early management for deteriorating patients, but they're not accurate for all groups of patients. In response to this, the CARM score was co-developed with clinicians and patient and public representatives and tested. CARM combines NEWS2 with routinely collected blood test results, age, gender and COVID-19 status. It has been demonstrated to be more accurate than other risk scores, and it does compare well with senior medical judgment in identifying a patient's risk of mortality. However, we don't know factors governing successful implementation of the score. This evaluation aimed to understand the first-hand experience of clinicians interacting with CARM and making clinical decisions relating to individual patients. Moving on to the methods, CARM was integrated into an in-house electronic health record system at a pilot hospital site that had a mature infrastructure tried and tested to combine NEWS with blood test results. The score is displayed on the patient record home screen with 0 equal lowest and 1 equal highest risk of mortality. By clicking on the score, each component of CARM can be shown, and users can also select a chart function to show trends in CARM scores for the admission episode. Prior to piloting the score, iterations to it were informed by collaborative workshops and focus groups with clinicians, patients and their carers at 2 hospital sites. Then in December 2020, around 123 members of clinical staff, which included medical consultants, specialist registrars, consultant intensivists and critical care nurses, were given access to the score. And this included guidance on how CARM can be used and links to various support material. Approximately 4 months after this, clinicians were invited to share their experiences of CARM in exploratory interviews with researchers. The interviews were designed to understand their experiences of the score, how they had used it with colleagues, elicit further information on barriers and facilitators to score adoption and inform future development. So 9 interviews were conducted by a team of 2 researchers with mostly consultants and senior registrars. They lasted for an average of 29 minutes and were conducted between May and July 21. A reflexive thematic analysis of interview transcripts explored perceptions and experiences. Initial coding was undertaken independently in order to generate candidate themes, and these were discussed and refined in a series of researcher workshops and through discussion with our patient and carers and the hospital clinical governance group to facilitate a collaborative interpretation and produce a researcher commentary. A thematic map of views on clinical utility and implementation support needs was produced from the analysis. The map contains 4 main themes: current use, barriers and facilitators to use, implementation support needs, and recommendations for development. And I'll just spend a few minutes sharing with you some of the quotes from clinicians on the first 3 themes. Current use supported clinical judgment, as in this example of ceilings of care decisions, and providing a degree of reassurance. It also supported escalation for a DNR discussion early in the patient care pathway. It also challenged clinical judgment in instances where the score was worse than it was expected to be. It could be flagging up something that the clinical teams are not seeing in terms of how bad things are. Clinicians discussed a role for the score in communicating risk of mortality, particularly around discussions about ceilings of care with the family and its utility as a communication tool. And for others, the score was viewed out of interest rather than anything specific, and this was in relation to it not being part of established processes. Barriers and facilitators to use included concerns about litigation, being hauled over the coals if they'd chosen to acknowledge a score and not do anything about it. There's also concerns about the evidence base, including how the score had been validated and with which patient groups. And facilitators included ease of use, one number on a screen not demanding lots of attention, it being straightforward. Implementation support needs included a softly approach to roll out an integration within existing processes, improved access to the score, particularly for clinicians who were using remote distance computers and the length of time it takes to log in, and training and education in the components of the score and how to act on the information that the score provides. In thinking about the implications for this work, the strengths and limitations of the co-development with clinicians, patients and carers on the content, presentation, use and implementation of the score and interpretation of our findings. We also needed to adopt a flexible approach for data sufficiency to avoid more staff resource than necessary. So the pilot implementation of CARM has demonstrated its scope in supporting clinical decision making more generally and communicating risk of mortality. We've got insights into barriers to implementation and what supports adoption and use. We've got suggestions for improvement in the score, including improved presentation, functionality and additional data. And the findings could support development, implementation and adoption of other risk scores. Thank you for listening. If you have any comments or questions on this presentation, please add them as a comment below the video and we will read and respond. For further information about our work, please visit our website. You can also request further information directly from me.